So welcome and thank you all so much for joining us today. Our webinar today is on infection prevention and control practices. And essentially our webinar will take, it is a 1.5 hour webinar. Our goal really is to go through part one, which is understanding iPAQ and going through our routine practices. And then we're going to give you all about a 15-minute Q&A section. And then part two of our webinar will be the implementation process. And then we are going to go through just helping non-medical staff understand iPAQ practices and giving you all an opportunity to then have a second Q&A 15-minute period. Being mindful, however, that there are some questions that you might now want to ask in respects to part one that seep into part two. So by all means, the Q&A section is not exclusive to each specific part. It really is just to give you all an opportunity to then go through a second part and then ask whatever further questions you have. So again, thank you very much for being here. We're excited to be with you all virtually today. As you know, our topic is on infection prevention and control practices. And before we begin, however, we do want to give you all a little introduction of who will be presenting and who will be in our webinar today. So our webinar will be, part one will be presented by Danielle Monroe, who is a registered nurse at CHIO in the Infection Prevention and Control Department. We have two individuals, our special guest speakers, as we're calling them, from Ottawa Public Health. So Jennifer Lapp is a public health nurse and Audrey Downer is a public health inspector. And they're going to be speaking to the outbreak management portion of COVID-19. And then finally, the second part will be presented by myself, and I'm a community program leader with the community-based operations and partnership in response to COVID-19 at CHIO. So before we begin, I just would like to note that these slides are here to help organizations better understand what infection prevention and control, or iPAQ as the acronym we'll be using for this webinar is, how to think about your organizational needs to prevent spread of infection, and guiding steps to implementing iPAQ practices in your organization. So as always, and in all of our webinars, we've been very mindful and just give you all a bit of a disclaimer to always follow your public health guidelines and your ministry and funding guidelines for instructions on how to work with your clientele during COVID-19. So again, all these slides are put together based on all the government and the ministry directives, and we're hoping to just give you all a good overview of all those great documents that have come through and all the iterations and modifications, and to give you all an opportunity to have a fruitful conversation with our iPAQ practitioners that are here with us today. So without further ado, I'm going to hand the mic over to Danielle Monroe, and I'm just going to make sure that everyone is muted. So if I haven't muted you, if you can just mute yourself, and if you have any questions, to just write them down and wait till the Q&A portion, as we are recording this webinar and we do want the content to flow as seamlessly as possible. So thank you all very much. And Danielle, over to you.
Good morning, everyone. Welcome and thank you for taking part in our webinar today. It's a pleasure to be here with you and to support you all through these challenging and uncertain times. I just wanted to start by giving a brief introduction of myself. I am a novice infection control practitioner that has recently started at the Children's Hospital. I've been a nurse for over 20 years, and largely the base of my experience has been in pediatrics. However, I do in the very beginnings of my career have some community background and long-term care background as well. So without further ado, we'll get started into our slideshow. So first, we're just going to spend a little bit of time talking about the fundamentals and the elements about routine practices. So routine practices and additional precautions are the most basic of infection control practices. It's important to understand how routine practices can be applied to different settings and different situations. And routine practices refers to the iPAQ practices that are to be used with all clients during all care to prevent and control the spread or transmission of microorganisms in all care settings. Routine practices need to be incorporated into the culture of all settings in the daily practice of all care providers with all client interactions and encounters to lessen the risk of microbial transmission. So the True key elements to routine practices are risk assessment combined with risk reduction strategies. And we further break down these risk reduction strategies here to identify specific control measures that can be implemented to further prevent the transmission of COVID-19 in your space. So we look at the different practice measures and we've listed them here. And as you go down the list, they become less effective in their control of the transmission of organisms. So we'll start at the top, being the most effective, and the first group being administrative controls. Administrative controls are controls consisting of policies and procedures, staff education, ministry immunization programs like influenza vaccine, staff education, sorry, I spoke of that, healthy workplace policies, respiratory etiquette, monitoring of compliance, and feedback of information surrounding these practices. The next level of control is the second group of control is controlling the environment and engineering controls. Things like single rooms and bathrooms for clients, adequate space between clients in communal areas and in sleeping areas, cleaning of equipment and spaces, and dedicated hand hygiene sinks for staff. And then another piece to environmental controls would be like the placement of a client, say for example, like putting them in isolation. And lastly, but not leastly, is the control of practices. Is an area that you can impact transmission through having staff perform routine risk assessments, hand hygiene, and personal protective equipment. So when we look at the role that we have to play in the congregate setting is to ensure that there's routine practices in your facilities, because the goal of routine practices is just to prevent transmission of microorganisms and illness within your facility. And it's important that we understand and implement these practices wherever possible. And we're going to start by today looking just at understanding the chain of transmission, just to help with overall understanding of how infection can spread. We're going to spend some time talking about a little bit about organizational risk assessments, point of care risk assessments, hand hygiene, cleaning and disinfecting the environment and equipment, proper use of personal protective equipment, proper handling of waste and linen, education of clients and families, and restriction of visitors. So it's always important to ensure, as we prefaced our presentation here, with ensuring that these are in accordance with your local or territorial public health. And we'll go into a little bit more details about these practices now. So in order to, I think, really solidify everyone's understanding about how illness is spread from one person to another, and to give you a really good foundational approach to teaching your staff and clientele about how this happens, we're going to spend a little bit of time just briefly talking about the chain of transmission and understanding how the chain of transmission is responsible, all of the links are responsible for the transmission, and then what we can do to interrupt or break the links of the transmission chain in order to prevent infection. And we can do that by applying routine practices and additional precautions. So in order for an infection to truly spread or transmit from one person to the other, each link in the chain must be present. And this is just a really good visual for you that you can use to show your clients or your staff. And it's just really breaks down to you in detail each link and what each link looks like and what each component is. So let's just take this down and look at it from a COVID-19 perspective and how that relates to the chain of transmission. So we're going to just talk about a clear scenario here to allow you to fully get the picture of the chain of transmission. So we're going to use an example of Bob and Bill, and Bob and Bill are in your space having lunch together at a table, but there's less than 2 meters distance between Bob and Bill. And Bob, unfortunately, is a asymptomatic carrier of COVID-19 or an early incubator of it, thereby not presenting with any symptoms at this point. So the reservoir is Bob. he's eating and he opens his mouth and he coughs a little bit, and a little bit of droplets come out and of his mouth. So by way of secretions, the portal of exit is his cough, and the aerosol or the droplets settle onto the table, and Bill reaches for his cup and takes a drink and contaminates his hand, but then contaminates his mouth with some of the aerosol droplets on the table from Bob. And so this mode of transmission is contact transmission, and it enters by portal of entry into Bill's mouth. And if Bill is the susceptible host, then if he has an underlying condition, is immunocompromised, is frail and elderly, or just in any way not extremely healthy, or it's a possibility that he could obtain COVID-19 from having lunch in a close space with Bob. So just to give you an understanding of that's how easily and how quickly it can transmit from one person to another, and gives an idea of why we recommend greater than 2 meters of distance in between individuals at this point in time. So to go a little bit more detail, the method, the mode of transmission is basically how an infectious agent spreads from one person to another. And there's different routes by which this happens, which are contact, droplet, or airborne are the different transmission routes. We know that COVID-19 is transmitted via droplets during close and unprotected contact and close encounters with individuals. We know that airborne transmission has not been documented for COVID-19. However, aerosols may be generated during high-risk medical procedures performed, called aerosol generating medical procedures, or AGMPs is the acronym that you've likely heard thrown around in some of the literature as well. And when an aerosol generating medical procedure is performed, airborne transmission could occur. Typically, this is not a type of procedure that would be performed in your space, I'm assuming. They are generally types of medical procedures that are done in acute care facilities, or that require an N95 fit tested mask, that require an airborne infection isolation room, and or a room to be left vacant, or specialized conditions around how the care of the environment is taken after the procedure is performed. There may be some instances in your facilities where individuals likely have a trach or other kinds of nebulized respiratory medications on like a routine basis, and those would fall into the list of an aerosol generating medical procedure. And so we just wanted to make sure that everyone knew that more than likely these procedures wouldn't be performed in your space, and in the event that they would be identified as a procedure that's performed in your space, it would be important that you connect with public health and to just talk about how you would manage that. But for the most part, is not likely to be a procedure that you're going to be seeing performed in your spaces, and they're usually for like emergent respiratory airway management. And so we'll just move now on to the next slide. And we did include a list of the AGMPs that are available for you all to have at your disposal to reference. And the next slide that we're going to talk about is a little bit more depth of the modes of transmission. So contact transmission is through the means of coming into physical contact with someone who has an infection or something that is contaminated with a virus or bacteria. And contact transmission can be through either direct or indirect method. So direct contact is if you touch someone with a respiratory infection and then you touch your eyes, mouth, or nose, and you might be exposed to the illness or become ill. So for example, if someone coughs into their hand and then you shake their hand, and the infection could be transmitted to you in that method. Or indirect contact, if you touch an object that's been contaminated by someone with an infection, and then you touch your eyes or your nose or your mouth, and the bacteria or virus could be transmitted to you through that method. When we speak about droplet transmission occurs when large drops are generated through coughing or sneezing or speaking loudly within 2 meters of a susceptible host. The droplets enter the susceptible host via the mucous membranes of the nose and the mouth, and the droplets can stay suspended in the air for only a short period of time. And many organisms that are transmitted via the droplet route are characteristically fragile organisms, and they can't survive in the external environment for long. They don't tend to live on surfaces for long periods of time outside of the body. Examples of those types of organisms are meningitis, influenza, or group A strep, to name a few. The next type of mode of transmission is airborne transmission, and it occurs when tiny particles smaller than 1 to 5 micrometers are generated through coughing, sneezing, or speaking loudly, or through those procedures I spoke about. They're very lightweight in nature. They can travel great distances on air currents and wind currents and dust particles. They can survive in the environment for several hours, and these infectious agents can get inhaled into the lower respiratory tract of a susceptible host. Examples of organisms of this nature would be chickenpox, tuberculosis, measles, and so on. So to give you, just to outline the examples for you of the difference there. So now let's talk about what we can do in your settings to break the chain of infection, and what we can do to achieve this. So breaking the chain of infection can be achieved through disruption of any of the links with the control measures that we'll discuss further that to reduce the risk of transmission. Routine practices and additional precautions will disrupt transmission of infectious agents and protect both healthcare providers and clients. Control of the environment and administrative controls implemented will disrupt the chain of infection at many of the different points. And this slide is a really good example, breaking down in more detail for you the components on how you can break the chain. And it's one of the many resources that are at your disposal that you can source to understand how specifically these measures are implemented and what part of the transmission chain they affect. And just because we spend a lot of time in the presentation today speaking about the ways we can reduce the risks, I just want to take a moment to highlight just quickly how what measures or what factors can inversely increase the risk of transmission. So an example of factor that can increase transmission of infections in the space would be high staff to client ratios, crowding or lack of availability of single rooms, shared bathrooms and sinks, poor cleaning practices, sharing of equipment and not being cleaned in between clients properly, poor hand hygiene. Children and cognitively impaired clients can obviously have an effect on the transmission just from not having the knowledge to act safely. And characteristics of the pathogen, depending on what we're dealing with, that some can spread more easily than others. And so there's many factors that can dictate the need to have really solid routine practices in your setting and by your staff. So a major responsibility of all facilities is to have the organization's responsibility in ensuring routine practices, the evaluation of the components in the hierarchy of control that we spoke about. It's the organization's responsibility to minimize the risk of exposure and transmission of microorganisms in your facility. And one way that this can be achieved is through an organizational risk assessment. It's a recommended practice to conduct in a way to ensure that you are doing everything you can to make your space safe for your clients and for your staff. They should be conducted on an annual basis, organizational risk assessments, and they should be reevaluated when there's any reorganization of the or restructuring or renovating or building in the facilities, and they should take place in instances like this where there's a true threat of an organism in our environment that we need to address, and be sure that we've done everything we can do to keep our space safe and our people in our space healthy. So organizations have a responsibility to provide the information and to train healthcare professionals regarding the findings in the organizational risk assessment, and then to translate that into how that impacts their practice. One way that this can be achieved is through signage in your facility, and we've included some links here and some just topics of which we would recommend that you have some messaging about in your space, and specifically how we've included some examples about some signs. There's a plethora of available signage and images that can be used, and we would just recommend and keeping in mind to put the signage in areas where the behavior is that you wish to guide. So you want to have your hand hygiene signs where you're doing hand hygiene. It'd be important to have physical distancing signs and messaging in a space where there would be a risk for not maintaining physical distancing. Universal masking signage is good to message at the entrance to your facility, but then throughout your facility. And then it's a good thing to have some of this messaging in space where your clients will be, in order for your assisting your staff and your clients to understand their role in all of these iPAQ measures and how that they can impact the safety of where everyone's living and staying by what they're doing. And this will help support kind of that messaging and that reminding, especially in areas where people clients are developmentally challenged, and having a visual reminder for them and families and busy workers to just keep that messaging at the forefront of their minds. The next step that we'll talk about now is the purpose of a point of care risk assessment and why that's necessary. So it's important to complete a point of care risk assessment before all interactions with all clients to determine how to safely care for and interact with the client. And it's going to help really answer the question of what PPE do your staff need to wear and when, and how that is appropriate for them. And it's important to ensure that they're really concrete on performing this risk assessment, because it's going to be the skill and the steps that's going to help mitigate the risks and prevent exposures to the staff and to these infectious diseases and to COVID-19. So it's really the only way to ensure that when they're working with the clients that they are not going to get sick, and that they're doing what they can to keep everyone safe and to keep your space safe. So we ask that it be performed on a routine basis, and it just start to be ingrained in their way of thinking before they enter a client space or interact with the client. And it's their way to sort of reduce their risk of exposure in general to bodily fluids, not just COVID-19, but to bodily fluids and exposed to blood and non-intact skin, and identify strategies that's going to help to decrease their risk of exposure and decrease the risk of transmission of organisms within your space. And they'll need to be, it's important that your staff are educated solidly on this, and that they understand that it is the fundamental practice that's going to keep them safe while they're working with clients. So we've included on the next slide a point of care decision tree as a reference document for your clients and your staff to use. And it's a resource that's available through Public Health, and it's essentially a decision tree to help guide step by step how a point of care risk assessment is to be performed. And it's going to ensure that your staff know how to go through those steps. And it might be a good idea to have this available for your staff in the initial phases of the education around this, and implementing it before their practice points. And if they need to reference it, then they've got that available for them to do so. And so it's basically what you want to message to your staff as how they're going to keep themselves safe when they're working with their clients. So we want to just spend a little bit of time now talking about how a point of care risk assessment relates to personal protective equipment. And we've done a lot of work already. Mary has with another one of our wonderful CHEO nurses to outline how your staff can be informed on what PPE to wear when and how to put it on and take it off properly. And so Mary and I has included a link here to this webinar for PPE coaching that's really valuable. It has a visual demonstration for this practice for your staff, and it's going to be what is you can use to connect your point of care risk assessment to your PPE and help to facilitate the knowledge acquisition of your staff. So that video is a very, very comprehensive video, and I think you'll find it very useful in your space. So let's now talk a little bit about hand hygiene and what that means. Hand hygiene, as we know, is considered the most effective iPAQ control measure to prevent the spread of infection. And all staff, volunteer, clients, and people entering and exiting the facility should follow hand hygiene practices that are recommended. We recommend that hand hygiene be performed in the 4 moments of hand hygiene, and we have a slide outlining that. We also recommend that it be performed when entering and exiting the facility, before and after eating, when hands are visibly soiled and dirty, and after coughing and sneezing. We know that when hand hygiene is done correctly, it can reduce the spread of infection, but our greatest problem is compliance with proper hand hygiene has historically been poor. So it's super important that there's the appropriate steps and signage in your space outlined as a visual reminder and to show staff the importance of the thoroughness that they perform their hand hygiene in. Infection control is one of the most, hand hygiene, sorry, is one of the most effective ways that we can reduce the spread of infection. And it's the only way that we can really ensure everyone's safety is by ensuring that everyone is performing as strictly as possible. Okay, and as we spoke earlier about just, we've given you a couple of examples of the steps of using alcohol-based hand rub for hand hygiene and for hand washing, and they're the ministry steps that are outlined as a reference that are available for you, and we encourage those to be posted in hand hygiene spaces. It's also really important that hand hygiene supplies be kept at the point of care where the client is, and if that's not possible because of special considerations in your space, then we recommend that you think of alternative methods or making alcohol-based hand rub available to your staff to carry on themselves personally to ensure that that compliance and that just-in-time use is easy and available and for them to do. We also encourage that you have the supplies for hand hygiene at the entrance and exits of your facilities, and that when using alcohol-based hand rub, that it has alcohol content no minimum of 70%. And it should be used at all points of care when soap and water is not available. So we would like to recommend that obviously you use soap and water when your hands are visibly soiled, and alcohol-based hand rub in between as a method of controlling spread of organisms. We recommend that only liquid or foam soaps are used, that soaps in bar form be reserved for personal care, and they not be used as a shared community product. We recommend using paper towels to dry hands, and if that's not possible for some reason, then to have designated towels for individuals in the space, and to not share towels. And to facilitate getting rid of the paper towels and ensuring that you're not recontaminating yourself when disposing those, we recommend having open top touchless garbage disposals at the point of hand hygiene as well. So the next 2 slides, Mary's just going to go through them really quickly here to show you. These are the diagrams that we recommend you putting in the places where those types of hand hygiene is being performed. So congregate living environments and facilities are not unlike healthcare environments. They can harbor many microorganisms capable of causing infection in susceptible individuals. And cleaning should be performed in congregate living settings on a routine basis in a consistent manner. And we recommend that that be done at minimum once a day, and that all staff that are doing the cleaning make sure that they're using products that are not expired and that they follow the appropriate manufacturer's directions when using these cleaning products. Cleaning, we recommend that you dedicate the adequate resources to support adequate cleaning as a measure of infection control. And this can be achieved through appropriate cleaning products, written policies and procedures for cleaning and disinfection of clients' rooms and spaces, disinfection of equipment, and identifying how to clean these spaces and how often to clean them, and that you provide education and training to the cleaning staff. That you provide a capacity to increase your cleaning in the event of an outbreak, that you would need to increase the frequency that you're cleaning a little bit more often, and that you're ensuring there's ongoing monitoring of the cleaning practices in your space. Routine cleaning is highly integral and important and should be done in a consistent manner. And we are recommending that bathrooms and shared areas like a kitchen be cleaned twice a day, and that other high traffic areas and high touch areas like doorknobs, cupboard handles, sinks, taps, etc. Be cleaned more frequently than once a day, and to have staff be mindful of if these spaces have been contaminated, then they would need just-in-time cleaning after the contamination happened. We recommend that all clients under suspicion of COVID-19 or positive for COVID-19 have their rooms cleaned at minimum twice a day, and that you disinfect and clean all critical and non-critical medical equipment thoroughly between clients. One of the other recommended cleaning methods really strategies to help with assisting with cleaning is by reducing unnecessary items in the area, ensuring that you have the proper cleaning supplies and that the proper frequency of cleaning is performed, that staff are ensuring a safe and proper disposal of waste and linen. And one thing to note is just that staff are aware that when a lot of the products that were supplied now from manufacturers come in the form of a wipe with a cleaner immersed into the wipe. And it's important to identify that staff, when they're dealing with large amounts of soiled material, that they remove as much of the soiled material as possible, and to then disinfect with the wipe after the large amount of soiled material has been removed. And if it's not done in this order, it just compromises and risks compromising the integrity and effect of the disinfectant. So just to be mindful with those types of products being used. The next topic we talk a little bit about, not too much, but we provided a really good reference point for you here to source more, is laundry when working with symptomatic clients. It needs to be done in warm or hot water and allowed to thoroughly dry. Staff are required to wear PPE gloves and a mask when handling the dirty laundry of unwell clients, and that it's important that they keep it away from their body and try not to contaminate their own self when handling the linen. And in the event that the linen or any of the environment became contaminated by the soiled laundry, it would be critical that the staff disinfect that area that's been contaminated. And then here you can resource more information about shared laundry facilities in your space through the Ottawa Public Health website. Okay, and so next we're going to really just talk about transmission of COVID-19. We know that COVID-19 can be spread through an asymptomatic person or a person that doesn't have any symptoms. And this is why currently the province's standpoint for recommendations of universal masking has been implemented in order that we protect ourselves from anyone that could be carrying this and us not know that they are an asymptomatic carrier. And so it's recommended that a non-medical grade mask be worn when not in direct care service with clients and when unable to maintain 2 meters distance between people. So what we really want to message when we're talking about COVID-19 and asymptomatic transmission is that routine practices that we've recommended that be implemented into all care workers' practices are designed to help to keep them safe and to keep the spread of transmission of COVID-19 down and low, and that if they consider it and they treat all clients as potentially as if they are a source of infection or they do have some kind of infection, then they're going to be practicing in the safest way that they can be practicing, and that the most important preventative measure is to always perform hand hygiene and to wear the appropriate PPE where they feel that they need to. It's important that on a routine basis, individuals assess and identify any signs and symptoms of COVID-19 immediately. So it's important that the staff kind of be mindful of how people are feeling on a daily basis, the staff and the clients themselves, and that if anyone identifies that they're feeling unwell, that they inform your supervisors or the appropriate supervisor or manager to take the appropriate actions to ensure that they reduce or stop the risk of any potential transmission in the space from the unwell client. It's important that when you identify someone that is ill or someone that we know has COVID-19, that you limit the number of staff caring for and providing for those people. So really be conscientious about who's interacting with those clients and try and limit the amount of exposure that you're having between multiple people, if at all possible. And ensure that that client is performing good hand hygiene, and if they're at all able to, wear appropriate personal protective equipment. If the client can put on a mask, that would be the best case scenario for everyone, really. So what we need to think about when a client becomes unwell, they need to start thinking about identifying what specifically they feel unwell with, and it's a good way to do that is through the self-assessment tool that's provided by the Ministry of Health, and that you then ask the client to remain in their room at all times, and unfortunately they will need to eat their meals in their rooms if at all possible, and not to share a bathroom with other residents if possible. And at this point, you would contact your local public health to discuss testing and best practices around getting a client tested for COVID-19. And so what we want to talk now a little bit about is how your staff can practice safely and consistently, and sort of messaging that before working with any clients, they perform a point of care risk assessment with all client interactions, that they practice strict universal precautions by using the right PPE in the right situation, that they perform thorough hand hygiene in all 4 moments of client care, that they avoid touching their face at all possible, try to physical distance as much as possible, and encourage people to practice really good respiratory etiquette. It's important that your staff know the signs and symptoms of COVID-19 and how and when to observe for these symptoms. And generally at this point now, most people know that COVID-19 sort of presents like a cold typically. Runny nose, cough, sneeze, nasal congestion, difficulty swallowing, hoarseness, all of those sort of respiratory concerns. But we included here some of the lesser well-known symptoms and the more subtle symptoms that staff need to be considering now and be mindful of when working with individuals, like unexplained fatigue, general malaise, an acutely altered mental status, delirium, an increase in their decrease in their functional abilities, any exacerbation of chronic conditions, any digestive symptoms, nausea, vomiting, diarrhea, abdominal pain, chills, headache, a rash, or changes to their skin, their dermatological state, and if there's a development of any new onset neurological symptoms. So those are the more, that's a more thorough list of the symptoms that patients or clients with COVID-19 could potentially present with. When working with symptomatic clients, it's important that additional precautions be implemented immediately, and these are encompassing of routine practices, specialized accommodation and signage, ensuring that outside of the client's room there is signage to say that appropriate PPE must be worn prior to entering to the room, that there should be dedicated equipment and additional cleaning measures in place for this client, that in most cases want to limit transport, and of course communicate thoroughly and openly with the client and the staff around the expectations regarding hand hygiene and respiratory etiquette, and expectations about behaviors within your space, and being really open and upfront with how you expect clients to be performing and behaving when they have an illness that is highly contagious for other individuals. Excuse me, just gonna take a drink here. When we talk about working with symptomatic clients, that we encourage your staff to monitor clients that have developed symptoms several times a day to ensure that their symptoms don't worsen. And so in addition to the routine practices that they have been implementing, it's important that they wear the appropriate PPE, which would consist of droplet contact precautions PPE, as they are termed, gloves, gown, and a mask with a visor and face shield when they're not unable to maintain the 2 meters distance, and they're providing intimate care like oral care and daily care tasks, and working with clients' bodily fluids and so on and so forth. So tasks that don't require close contact with or direct contact with individuals who are otherwise healthy and display no symptoms of COVID-19, you're just required to wear a non-grade medical mask, and that can be a manufactured one or a homemade one that we've been so blessed with having available to us. The next thing we just wanted to talk a little bit about is that the discontinuation and the duration of the precautions should be determined on a case-by-case basis and in consultation with the public health unit in your territory, and making sure that everyone is aware of the practices around the additional precautions that you've put into place for this client. A client who is asymptomatic and on home isolation due to a high risk exposure, like travel to an impacted area in the past 14 days, or close contact with a person with acute respiratory infection who has been in an impacted area, or close contact with a confirmed or probable case of COVID-19, they should be placed on they should be placed on droplet contact isolation precautions for all interactions until the determined timeline that you've spoken to your local public health unit about has been reached. And so now we'll talk a little bit about if staff or volunteers become unwell, and the staff should be aware of the signs and symptoms that we spoke about, and you should be advising them we should be advising them to stay home if they identify to be having any of these symptoms. And you want to have staff ensure that they're checking and monitoring these symptoms that are compatible with COVID-19, monitoring for those before every shift. And they can also use the self-assessment tool that's provided by the Ministry of Health if they're unsure of any of those symptoms. We want them to follow the directions that are on the self-assessment tool, and obviously check in with the appropriate supervisors if they've identified that they've become symptomatic. And if staff or volunteers become positive with COVID-19 or in close contact with a client or person that's positive or suspected of COVID-19, they should also contact the supervisor and discuss plans for moving forward on how you want to proceed with their direction. And so now We've covered all of the basic fundamentals of what we can do to prevent the spread of infection within your space. And we'll turn over the presentation to the Ottawa Public Health ladies, to our special guest, to speak about what you can do in the terms of managing an outbreak in your space. And I thank you very much for joining us today.
So I'm good to go?
Okay.
Okay.
Jennifer, it's your turn, yes.
Okay. All this technology. Okay. So my name is Jennifer, and I'm a public health nurse, and I work for the Infection Prevention and Control Inspections and Investigations team. It's a team of public health nurses and public health inspectors. So I'm here with Audrey Downer today. So I'll just give you a little background about myself. I have worked at the supervised injection site with Ottawa Public Health. I've worked with the homeless population in with regards to tuberculosis. I've worked with vaccines and different things. So I'm well aware of you know, the some of the difficult things that happen with this population.
Jennifer,
Next slide. Yeah.
Okay.
Sorry. Okay. Oh, I didn't unmute myself. Okay, so I'm with Jennifer. So I work on the infection prevention and control team, and it's a combination of public health nurses and public health inspectors. I have worked in the supervised consumption site and with the homeless population with regards to tuberculosis. So that's kind of a little bit of my background. And now I'm on the iPAQ team, and we can go to the next slide. So outbreak management. So COVID, there are many, there's a list of communicable diseases that are reportable. So the ministry gives out this list, and public health responds to positive results from the list that they are given by the ministry. So COVID-19 is a reportable respiratory disease, so it is on the list. And anytime a positive result is received, all public health units get these lab results and respond to these results. Next slide. Defining an outbreak of COVID-19. So the ministry identifies what makes, what classifies, what the definition of an outbreak is, okay? So there's different things, different definitions for different respiratory or enteric or communicable diseases definitions. So for COVID-19, the definition is one or more lab-confirmed resident or staff COVID-19 cases associated with the facility. And I just wanted to emphasize that sometimes there are exceptions. So when we do receive a positive result, we have to go into the detail of how, what type of role that person played in the facility. So if it's somebody delivering something, a regular guy, and he comes in, that might not be deemed an outbreak. So there's like different rules that apply to that, but that's the basic rules now. So we can go to the next slide. Working with your local public health unit, okay? So what we need from you guys is we want you to know that anytime that there is a positive case, you will be contacted by public health, somebody in public health, okay? Of any positive results, regardless of what it is, as long as it's on that communicable disease list. So the outbreak team is responsible for is they're responsible for whether that case meets outbreak definition. So we decide whether it's an outbreak or it's not an outbreak. If it is decided that it is an outbreak in the facility, will be assigned an outbreak number, and further monitoring will be done by our iPAQ investigators, okay? The thing that we ask is that you follow all COVID-19 control measures. So when we do decide that it is an outbreak, all this stuff is going to be reviewed with you over the telephone. We're going to conduct a site visit. We're going to give some recommendations and stuff like that. In regards to testing, it will be the public health unit that advises you if further staff or resident testing is required. Okay, so we're working with you for the whole outbreak. And another key point that we want to say is that it's really important that daily communication with your investigator happens when it is deemed an outbreak. And it is public health investigator that decides when the outbreak is declared over. Okay, and that's it for me, Danielle.
Great, thank you very much, Jen. That was wonderful. So now we're just going to take some time. We're going to have time for about 15 minutes of questions and answers. And just be mindful that Mary already said earlier that there's also another Q&A period. So if you're not able to get your question in, there will be other time at the end to do that. And they don't have to relate pertaining to the specific sections in the Q&A. And that if there's any questions that we're not able to answer today, or if it's a little bit too detailed or too specific to your space, please take the time to send an email after, because we really want to address all of your concerns that you may have. So we'll open up the floor now, and Mary will manage the questions. If you have a question, there is a place on Zoom that you can raise your hand, and then it will bring you to the top of the list and triage the questions as they come up. So feel free to raise your electronic hand and indicate if you have a question or concern.
Sorry, I can't find my button for the raise the hand. So
there you go. Yeah, that works too. The old-fashioned way also works.
I sent a question through chat, but I don't know if you guys got it or not. Lori from Tamir in Ottawa, and just wanted to get your input on, over the course of time, we've ran into a few people being tested that we support. All, thank God, were negative. And in this particular case, as time has gone on, gentleman goes to hospital, non-COVID related, on intake, gets tested negative. He's been there about a week, I'd say. And we're being told now from public health, it's the first time actually since COVID started where we've had a person in hospital, tested negative, and then he has to come home and still self-isolate. Is that sort of what you're familiar with, that scenario?
That's a really good question. And yeah, so what we typically do at the hospital, or just typically in general, if there's been a known exposure, so the reason there must have been a reason that they've tested him, because we know that even asymptomatic transmission or early incubation can transmit, and the negative precautions, even though he's negative, precautions still need to be taken place for 14 days from the initial contact or defining of that exposure. So if they're defining, say, just for example purposes, the day he was admitted or the day before he was admitted, he had exposure to someone or started presenting at that time with those illness, you would expect that for 14 days then after he would be isolated. Yeah. So 14 days, if that 14 days came in while he was in hospital, then that time period is up. But 14 days or resolution of the symptoms that he's having, and those symptoms need to be gone for 48 hours before he can come out of isolation.
Yeah. So there, first of all, it sounds like the hospital, for the first time since we've been in COVID, tested on intake, or on admission. So in other words, he went to hospital and shortly after was tested. he went to hospital with a bladder infection and blood in his urine. So anyway, so they
So
might,
if he doesn't have a known exposure to someone that was
that's the
ill or
question.
being ill, then he is tested negative and he's asymptomatic. You only have to isolate for the 14-day period if there is a known contact with an exposed individual, someone who traveled to an exposed high-risk area, or someone that is presenting with like a potential situation. So if he only went because of an isolated personal health issue that met the criteria as potentially symptomatic for COVID-19, they screened him, he's negative, but he's not been in contact or have a reason to have people think that it's COVID-19, then he doesn't require isolation.
So I have a question. Sorry, it's Christine Rondeau. I think the confusion lies when they say things like that your person needs to isolate for 14 days. But if they have not been exposed, first of all, if they've been exposed, it should state that on the discharge summary. And something should be provided to the residents, and as well as a conversation with the residents. So we had one young lady who was in hospital, not COVID related, bladder infection, returned to the residence, was not advised. She was discharged at the downstairs door. No, very minimal documentation with regards to the discharge. No contact with a nurse upon discharge because she was dropped at the door. A week and a half into her return to the residence, we received a call from public health saying that she may have been exposed at hospital. And I said, great, now you just exposed our whole potential home. And they said, well, our contact tracing isn't, quite up to snuff yet, but we'd really like you to put her in isolation for the final 3 days of the 14 days. And I'm like, you have got to be kidding me that we have to now put her in isolation for the last 3 days of the 14 days. She hasn't presented any symptom signs or anything. There's zero documentation. We thought it was ridiculous, but we did. And they said if she doesn't show any signs after the 14th day, she's free. But things like that shouldn't be occurring. If somebody does have a contact with somebody in a hospital, that should be flagged and notified before the person is discharged.
It absolutely should be, you're right, and that shouldn't be happening. However, one of the things that you can do on your end to mitigate all of that is to ask those questions on intake back into your facility and address those concerns prior to the patient or client coming back in.
And speak to the discharge planner.
Correct.
I had
and ensure that you have identified 100% that what they're recommending is in place, and that they can be sure that if the client hasn't had any contact. I mean, we have a due diligence to do that to prevent spread from facility to facility, and that is now why they're doing a lot of admission entrance screening to prevent outbreak transmission from facility to facility.
But why wouldn't they do discharge screening as well?
I can't really speak to the practices that they have in the hospital. I can only make recommendations for how you can practice safely moving forward.
Right.
We were told that they wouldn't do a second test, but I'm going to talk to discharge directly just to find out, because if there is a concern of exposure, then why wouldn't they test again?
Well, because testing again could be negative and then inconclusive and not tell you anything. So the important thing that you can really impact is your screening and your precautions around that, and knowing who's been in contact with who. Testing doesn't really tell us what we need to know. It's good to know, but what we really need to know, because we could test one day, they'd be negative, and then the next day they could be positive. So we've known they had a known exposure. That's where the precaution needs to be placed. And that's where the considerations.
That's very helpful. Thank you.
You're very welcome.
I just wanted to add a piece to that is that regarding the testing as well is, so first of all, things with the ministry at the beginning was changing every day. And as we, COVID was something new, and as we learned things that were happening, our medical officer of health would make changes. So the ministry recommendations were the minimum, but there's sometimes, it's not just so black and white. So every area is different. So if our medical officer of health had information and knew, hey, we better up this a little bit because of this. Right? So there's lots of discussions like back and forth. And when you do the case management part of it, with a case, it's like an 1.5-hour interview. And we go through, what did you start your day with? It's a very detailed, and then we pull out, it's very detailed. We talk with one of our associate medical officer of health and identify any risks in there. It's a very detailed process. And there's lots of people discussing, what if this, what are the recommendations? So, yeah, and the other thing is that sorry, Danielle, I believe it's not 48 hours now, it's 72 hours symptom-free. So, that changed from before because they learned new information and they said, we better do this. The other thing with testing is testing is a point in time. Just because somebody's negative, don't think that they can't turn positive. I've seen people turn positive a day later.
Sorry, I have a question then around that, because we have now all been legislated, anyone in congregate care, where our families who come for visits, same as in long-term care, need to a negative COVID test within the past 2 weeks.
That's right.
It doesn't make any sense, because they can go get tested and then be exposed and then bring it to the residents. So how are we supposed to mitigate that? Yes, we have screening tools. Absolutely, we do. But like the point in time testing is really a false sense of security. It doesn't really provide what we need, although we are now legislated to do that. Our families are now legislated to go and get tested every 2 weeks if they want to have a visit with their person.
So the thing is, so when you have a case, and let's say they had, first of all, no symptomatic person should ever visit. That's straight. But when you have a case, and let's say they have a positive result, okay, this is how it's done. What we do when we do that detailed information is we say, okay, what's the date your symptoms started? Okay, it's very detailed. So if their symptoms started yesterday and they got their positive test today, we go back from the first symptom onset, 72 hours, and anybody that they've been in contact with from that before that 72 hours up until their last exposure where they're supposed to isolate could potentially have gotten the virus, right? But anybody before that, we know it can't spread during that, before that, right? So we know that. And then that's how we identify the contacts, the close contacts, and stuff like that. Yeah, so if people, the messaging is, they want people to keep the distance, wash their hands and all that stuff. So they're hoping that those people are practicing those controls, so that it makes then they're hoping that people are practicing those controls, right? So they're relying on that too, that people are following all those controls that have been in place as well,
I guess it lends to the question of then why ask a family member to test if they don't have any symptoms, when it really, as Christine was pointing out, it sort of is a false negative, possibly. Yeah.
It is, but in one sense, it does do some good if we can catch something by testing that way. It is one measure of mitigation at the front line to start with. And it doesn't encompass and protect you 100%, but it's a small measure of control that could be put in place to maybe catch something that's asymptomatic, but has enough of a viral, the client or the person has enough of a viral load that it's testable, but not enough to present as symptomatic.
Right.
So it is a strategy to nip things in the bud beforehand as much as possible, but it's certainly not going to catch everything, and it's not it's the best I think that we really can do at this point, with not knowing so much about this type of
so I'm curious to know why you know, it would go to the families being tested and not the healthcare workers or our staff. Because our staff are really our weak link into the programs, right? The clients aren't going anywhere, right? Our individuals aren't in and out individuals. Well, most of ours, I don't know if everybody, but ours are not. Our clients have been locked down. They're home. It's the staff going in and out, and now the staff have freedoms to open up and be with more people and those types of things. So that's our biggest concern. Do you think mandatory testing will come into effect for staff, for people, healthcare workers, everyone, over the next little while? And again, I think it's curious to know why they went with families versus staff.
Well, they have provincially implemented a mandate to have all long-term care workers tested, so that consideration has been in place in the long-term care sector. Jen, did you want to speak?
But not regularly, though. Not regularly.
Yes. So, Christine.
Yes.
The other thing is the testing is 1 point, right? But the other control measures that you have, like for instance, staff, if the recommendation is if the 6 feet cannot be maintained, then your staff should be wearing masks, right? Whether they be the surgical mask,
They are. Yep.
So that is another control measure. It's not just one control measure that makes the difference. So if somebody's wearing PPE, that's going to prevent the transmission and washing their hands, that's going to prevent the transmission of the virus.
Right, for sure. And our staff have been wearing masks for several weeks, months now. But it's more so, you know, it's just a curious piece why they chose families versus regular testing for staff. That's all. I was just trying to understand, you know, what the logic behind that. And I know you probably don't know what the logic is behind that, but, you know, it's a bit curious for us, you know, to our staff are there every day. The families might pop in once a week for 30 minutes.
So my understanding of that kind of approach to mitigating risks is that family members and patients and clients themselves, we have less control over. With staff members, we do have more control. And so we've been able to educate them to understand what the symptoms are. We've recommended that they're doing routine and ongoing self-monitoring, and we directed them to the appropriate resources that they should be using to be knowledgeable on this. And that's the level of control that we've been able to implement there that we kind of can't put into the community. We can recommend, but we can't ensure that that's being done regularly. And so that is sort of the rationale between, I think, some of the rationale behind why we would test family members over healthcare providers who are working in those environments, but they have all the protective measures in place in those environments to mitigate the risks of them being transmitters. And we have ongoing compliance and auditing and monitoring of all of that to make sure that that's what's happening. We don't have that same level of control with families. So that is one way we can control to some degree what's going on with the public.
Yeah, that's great, Danielle. That's exactly.
Perfect.
We also know that the recommendations are evolving all the time. So whether or not these control measures are the limits that are put on families, this may change. We've seen many incarnations of the guidance documents over time. So as issues get recognized, there will be updating of those recommendations.
Perfect. Thank you so much. We're going to continue with part 2 right now, and I will go through it within, I'm hoping, 7 minutes, because I would like to open up the floor for the second part of our Q&A portion. So I'm just going to go back to sharing my screen right now. Perfect. Just going to minimize this. Excellent. So thank you all very much. And I can see that there's a lot of good questions coming through, and a lot of confusion, and maybe some greater conversations could be made. So if you have any specific questions and you would like some clarification, please send us an email. We are working in collaboration with multiple partners. So this is not just exclusive to CHEO and not exclusive to Ottawa Public Health. Our goal is to really understand the questions that are coming through with our partners and try to address any confusions that we're currently experiencing with any of the iterations and implementation and changes that are continuously ongoing right now in response and in respect to iPAQ practices. So right now, our second part, and I am quite mindful of time here, but just very quickly, our goal for the second part of implementation is really just to put forth a step-by-step process to help you all, now that you've had a good overview of what iPAQ practices are and the iPAQ 101, just to help put it all in place or structure it all in place, that if, for example, you find yourself, really emphasizing on certain sections or parts and not necessarily putting enough emphasis or gaps that you're noticing in your own organization, this hopefully will help you all kind of see what the steps are appropriately to set in place for your own best practices in your unique organizations. So essentially, our first step is continuous education on iPAQ. So the goal is understanding iPAQ and its roles in protecting your organization from COVID-19, so entry and spread. And questions to ask yourself are really to better understand, what category do I fall into? So questions that I'm sure you've already all have asked yourself and have all put in measures at this point in the COVID journey. Step 2 is, going back to Danielle's explanation around organizational risk assessment. So really putting in place and start asking your key questions to increase space and safety and risk of spread within your space. So, doing an environmental scan of your space, creating enter and exit points of entry for each room to try to avoid any crossover. I won't go through all of these, but one that I do want to emphasize is, for example, from an organizational point of view, if you find yourself in a setting where you are in a shared sleeping arrangement capacity where your clients are sharing rooms, when you think from an organizational point of view, you're thinking, okay, prior to COVID, maybe both of the beds were set where both heads were on one side of the bedroom and now the feet are placed on the other side. So allowing yourself to be mindful of how can I strategically rearrange the rooms, including the sleeping arrangements, bathrooms, etc., so I can try to enhance as much of that social distancing as possible. So can I flip one of the beds over so now both of the heads are at the furthest part of the room? So I'm preventing as much as possible and trying to increase as much social distancing or physical distancing within a confined space. And then earmarking one room, ideally the one furthest from the rest of the room, as your self-isolating room. Step 3 is essentially going through that environmental cleaning. So the goal around that is understanding how often, when to clean, how to clean, and really thinking again critically around the doorknobs, all the spaces and spots and items that are touched more frequently from a staff to staff perspective. So any devices and tools that are shared between staff, encouraging your staff to increase their own internal cleaning practices. So if you have the overnight cell phone or the on-call cell phone, for example, when you're done with that cell phone, encouraging staff and really emphasizing best practices around, cleaning and Viroxing or Lysoling the cell phone prior to then the second staff utilizing that same item, and then encouraging them to clean that item as well. So you're just increasing the cleaning capacity from both your housekeeping staff, but within your own staff as well, and your clinicians and staff that are not necessarily earmarked to be working from an environmental perspective. Your second step is, enhancing and increasing that entrance screening process. So if, for example, you don't have in place an entrance screening process or practice yet, really emphasizing and putting something in place, and then thinking around who are the types of people that are entering my space. So who are my essential visitors and who will become my essential visitors as the city starts reopening? Who are my current clients? As we start accepting new admissions, what do we do with our new admissions? Are we self-isolating for 14 days? Are we putting them, in higher precaution measures? If you have postal service drop-offs, like how does that postal service drop-off now look like? Staff and then your personal support workers, CAS workers, and any sort of external partners that come in to help your clients with care. And then if you've rolled out any universal masking, to create a one-pager explaining why you've introduced this practice in your space and really explaining the reasons and being transparent around increasing safety measures and trying to engage with some administrative controls. Step 5 is talking about that universal masking policy. So if your public health has recommended that your organization should roll out the universal masking, keep in mind the following when implementing said practice. Knowing the difference and really understanding the difference and the different terminology and language around what non-medical masks and medical masks are. So having a greater scope of understanding around the N95 masks, for example, and the usability and the reasons why they're being used. If your clients can wear a mask, how they wear a mask and at what capacity and when. And if they are able to wear a mask, giving them to the best ability, the expectations as to why they're now being asked to wear that mask. Your staff, so increasing that point of care risk assessment and ensuring that your staff know what type of mask to wear at every point of client work, whether it's direct or indirect. And if and when essential visitors are now welcomed back into the space, or any external support workers, what kind of masks they're able to wear. As at that entrance screening, they're entering the space because they've passed the screening, they're not symptomatic. So what kind of mask through your universal masking policy are you then giving them? And then putting together, as mentioned prior, a document explaining the purpose of that organizational goal. Step 6, again, is really going through your point of care risk assessment and allowing your staff and your clients to know why PPE or personal protective equipment is now being used and why that's now deemed a new normal way of doing business with your client to client, with your staff to client care, and then having a better idea and understanding when and where. So using that decision tree, and then if you have yet to give your staff our PPE coaching webinar, so they have demonstrations and an explanation and detailed reasons why PPE is now a safe and best practice for us during COVID-19. And then for urgent PPE, I have a link here. So I will be sending the slides to everyone. You can click on the link and see exactly how you can then navigate and ask for urgent PPE if need be. Very quickly, step 7 is when you're thinking critically around isolating a client, the goal of this is you're asking yourself, how are you now isolating your client who has either tested positive or currently being tested for potential COVID? So you're asking yourself, within my agency, can I self-isolate within my agency's organization? If I've established, if, for example, your organization has multiple dwellings, have you established one dwelling as the COVID-19 positive self-isolating dwelling or space? And if none of this is made possible, is there a potential of establishing a partnership with the community and utilizing an isolation center, for example, so you can try to ensure and minimize risk of spread in your own space? But again, always utilizing and tapping into your public health to better understand what that looks like when you're in that isolation period and when you do need to work with your clients and your public health around that isolating a client during COVID-19. So, things to consider as well is making sure your clients understand why this is happening. So if they are being asked to self-isolate in a different dwelling that is no longer their living facility that they've been in for months, giving them some clarity as to why. Making sure the PPE is available for your staff at the point of entry and giving them exactly the right tools and strategies to know exactly when to don or take on or doff, remove PPE, and other tips here that I will be sending as well. Finally, step 8 is talking again about hand hygiene and just making sure that that's part of the implementation process. So I won't go into this in detail, as Danielle did talk about this, and I am mindful of time, and I do want to give you all a little more time to do some Q&A. Step 9 is practicing together. So working with your clients or your clients' caregivers or your clients' personal support workers to really enhance and practice the hand hygiene methods together. Practice donning and doffing a mask together, because ultimately with this, the key or the big takeaway is that techniques and steps to proper hand hygiene and PPE donning and doffing is critical and very important to avoid spread of COVID or contaminating oneself or your environment. So those videos and visual aids that Danielle talked about at every point that you should be emphasizing and placing in your organization really should be part of the overall implementation process around iPAQ practices. And then that collaborative piece, so working together really enhances better uptake and less resistance from both staff, clients, essential visitors, etc. And finally, step 10, attempt and change. So at this point, we're hoping and we're suggesting that all agencies have the following processes in place. So physical distancing, proper hand hygiene, knowing when and where to don and doff PPE and how to do so, and an entrance screening process. So very quickly here, I will not spend too much time talking about this, but these slides again will be available so you can read through them. But stuff and suggestions that we've put in place around supporting your non-medical staff around PPE is really enhancing the discussion and being as transparent as possible as to why the iPAQ measures are now being put in your place or in the organization space, and really having a comprehension and some internal documents around why and the expectations and the boundaries you set in place for your organizational needs around iPAQ during COVID. Coordinating with your team, having team meetings, ensuring Q&A periods, additional questions that you may have that are very unique and pertain to your organizational needs, please reaching out to us, sending us a couple of emails. We are available for some virtual consultation. We're available through partnerships for some on-site consultation as well. So being mindful that this webinar is really a start should you require additional support. Putting those visual aids, allowing your staff to step out of their comfort zone and really giving them a lot of praise and emphasis, and really encouraging that the idea of PPE and iPAQ practices is not because there is COVID in the space, for example, but because we're really trying to minimize and really mitigate any risk and try to really ensure that this is now just the new normal and the new way of working within our agency until further notice. And then this is just additional information as well, and I'll give you all a chance later to read through it. But one of the bigger pieces for a non-medical staff like myself, for example, really is the less is more model. So the process at this point, as best possible, should be clearly stated using lay terms, and again, being very mindful that a lot of information and documents are constantly being flooded in our inbox, and our due diligence to navigate and comb through all the processes, but trying to really carve out the most important critical pieces of that and putting an internal document together and saying, this is what we're hoping, and this is our expectation of our space right now during COVID-19. And these are the rules and the steps clearly stated for us all to follow. So again, just being mindful and just thanking you all very much for partaking in our iPAQ webinar today. We did put together, and this is an ongoing living document, so it's an online toolkit. It's a hub essentially with all of the information for Congregate care partners and beyond. And really this is an online website, and it's a drop-down list of different resources like PPE coaching, iPAQ, ethics, staff wellness, client wellness, and so much more. So the link is here. There is a username and password for you all, but this document is made available for all of our partners. This webinar will be on that website as well. So I will then open the mic once again for some Q&A for Danielle and Jennifer until we're wrapping up here. So if you all want to stay an extra 5 minutes, if you have some questions, by all means, we're available for that as well. Okay, I'll leave it open for another 15 seconds.
I just want to, I don't have a question. It's Lori. I don't have a question, but I just wanted to say you're all doing a terrific job, and we're very appreciative. We've had to call public health a number of times, and they've been extremely, extremely helpful, patient, checking back, you know, and with powers above if they don't know the answer. The other really great process we just went through a while back is they got access for us to community paramedic service, which was just terrific. And they came in, tested an individual. They actually came back about 3 times to check on his health, and he tested negative, so it wasn't COVID related. So I just wanted to say thank you very much.
Well, thank you for that. It's very kindly appreciated. We heard that this was a need for our community. We did a congregate care survey, and this actually came up quite often, that some, you know, it would be nice to talk to a human. I mean, in the realm of what we can do from a virtual perspective at this point, but it would be nice to really have an open dialogue and conversation with iPAQ practitioners around how to implement and how to make sense of all the documents and all the directives that are coming in right now. So again, you know, we're very thankful and we're very happy to have put this together. This is not a one-time conversation. Should you have additional questions for any of us, by all means, we're here. Our goals really are to create a collective or a collaboration in respects to ensuring that you all feel safe and that you feel prepared to help your clients as we navigate through openings of phase 2, phase 3, and what it looks like from a city perspective. So it is 11:29. If there are no other questions, we will be signing off, but thank you very much once again for partaking in our webinar, and we hope to hear from you all very shortly. Perfect. Thank you all.
Thank you all. Take care, everyone.